The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Wednesday edition of our Safe and Calm webinars. This is Deanna Mitchell with Leading Age Michigan. Over the past week, it seems, or at least it feels to us, that the intensity of guidance and communications may finally be calming down a bit. But as the pandemic continues, we know that there's going to be a lot to consider and discuss as we move forward. So we're going to continue our twice per week scheduling for webinars, but we may cancel now and again when it seems like there is not really enough content to convene the group. Also, we want to remind everyone that the Governor's Task Force is beginning to start, and we are going to be using a lot of our information and advocacy to work on that group in its decision making as well. And so those meetings are just becoming scheduled as we speak. So for today, our webinar will follow our routine agenda. With the legislature on recess, Dalton will have a very brief advocacy update, and we will follow with a situation update. And it's looking a bit more positive for Michigan in terms of some of our numbers. And we will end, of course, with our standard set of resources and guidance. So with that, I will turn the presentation over to Dalton for his advocacy update.
Good morning, everyone. So I believe the process started 2 days ago. The HEALS Act at the federal level started coming out of the Senate in chunks. And now we're at a point where we kind of have a better picture, but it's still a little foggy as to what exactly is all in this. The HEALS Act stands for the Health Economic Assistance, Liability Protection, and Schools Act, which then makes HEALS. Federally, they really like their acronyms. So today I'm going to be touching on just briefly some of the highlights of what's in this act and a couple of things to watch out for us as an association. So as I said, the HEALS Act, there's your acronym again, is the Senate response to the HEROES Act in the House. This is the Phase 4 COVID relief package from Senate Republicans. It's about $1 trillion, and it has a strong education focus. So some of the general things with the act that you'll see kind of out in early articles, because these are kind of the things that people are interested in. It sets up enhanced federal unemployment insurance at 70% of a worker's previous wages up to $500. But this will not be rolled out until October. And until that time, the unemployment benefit would go to $200 per week, down from the $600 per week that it's currently at, that was established in the CARES Act. There would be another round of stimulus checks that would be about $1,200 for individuals. To qualify, I think you have to make less than $75,000, and then between $75,000 and $99,000, you would then see some of that fund being taken out of the check, so you would receive less than $1,200. It also provides $190 billion for more Paycheck Protection Program loans, or PPP loans, and then businesses with fewer than 300 employees who have seen revenue fall by more than 50% can apply for a second PPP loan. Another couple of important things is that there is no additional funding for state or local governments in this bill. There is in the HEROES Act, and so this is going to be one of the points where Senate Republicans and House Democrats will be debating. As you know, for FY 2021, we're facing about a $3.5 billion hole to the state budget, so this funding is really important when we're looking at the scale of our state budget hole. And then there's also no formal federal COVID response plan in the bill. For healthcare, a couple of things. The HEALS Act does create tax deductions for employer purchases of testing, PPE, and other supplies. There's $16 billion in new funds for state testing, $26 billion for vaccine research and distribution, $25 billion for the Provider Relief Fund established in the CARES Act, and it also extends the telehealth flexibilities until December 31st. It instructs CMS to report nursing home COVID numbers weekly and creates federal infection control strike teams. Please note that the funding for the infection control site strike teams is pretty low, so the actual ability for them to come help might be very limited. And then it does very little for housing providers. If you are following Leading Age National's stuff, you'll know that they are pretty upset that it doesn't do anything for housing providers. It does not extend the eviction moratorium. And overall, as a total package, Leading Age does not support the bill. Importantly, for many people, it does, the package, the L in HEALS, stands for liability protections. And these protections protect people from civil liability, and they are put into two categories. There's protections for businesses and protections for healthcare providers. The business protections are called exposure claims, and housing would fall into this bucket. They're much more general than the housing provider one, or healthcare provider ones. And the healthcare provider protections fall under medical liability actions, and this limits lawsuits to those that contain gross neglect or willful misconduct. And it also sets the standard of proof to clear and convincing evidence, which is higher than your normal standard of proof for your normal civil case. It also specifically states that staffing shortages and PPE shortages will not be considered gross negligence or misconduct. And they also define what a healthcare provider is very broadly. As you know, the state of Michigan was looking into providing some of these liability protections, and the problems arose when they defined what a healthcare provider is. This federal protection is very broad, and I have the exact language there. The intent is to cover anyone who provides medical services in response to the COVID pandemic. So this covers a bunch of provider types. I need to delve a little more deeply into this because it's still a little foggy. It's even hard to find the bill text right now. But I believe this would cover almost every provider type. My only concerns are around the unlicensed and assisted living categories, but I think there is something in there to protect those provider groups. And this would also set the statute of limitations for cases to October 1st, 2024, or until the declaration of emergency is over. And it's important to note that Leading Age does support this particular part of the HEALS Act. So that is something positive coming out of this. And that's all I have today.
All right, thank you very much, Dalton. Before we get into any questions, Leading Age Michigan would like to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos and the names on the screen. These are the organizations that continue to support the association and your organization as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of names and logos coming further on in the slides, and consider making a purchase from one of these fine organizations. I just have one question right now. Any update on the Lucido bill?
The Lucido bill, as well as the liability bill that were passed last week, are both kind of sitting on the governor's desk. It is kind of the expectation that she's not going to take any action on these, thus essentially performing a passive veto. I'll keep looking into it to see if anything changes, but that's kind of where we're at right now.
All right, thank you for that. I believe we are good to move on. So are you ready, Deanna?
Sure, let's move ahead to our situation update. So as we look at data this morning, we'll find that the U.S. caseload is still growing heavily, but there is some good news in some spots. So we're going to start with an updated version of a graphic that we've used a lot. And this is the display of the current 7-day moving average of daily deaths across the planet as of July 27. You'll note that almost every area is growing again in numbers, with rates in Latin America really peaking. The U.S. is still holding firm at 17% of all of the deaths on a daily basis, but that doesn't mean that the deaths aren't growing themselves. It's just that we are at 17% of all the deaths daily. And that is down from a high of 33% several months ago. But overall, we know that the numbers continue to increase along with the caseload. This next chart shows the daily caseload based on world regions. This is a WHO, World Health Organization chart as of 7/28. And you can see the surge is continuing most obviously in both North and South America. Note that these are just daily new cases. So it's obvious that most of the increase is still in the Americas. In terms of daily deaths, the same is true. It almost seems like the Americas have an even higher proportion of numbers compared to other regions. And so we're seeing increases obviously in both cases and deaths. So these are CDC maps that reflect the state-by-state proportion of cases and deaths per 1,000 population. So this isn't just total raw numbers, this is cases and deaths per population. And while Michigan seems to be growing in terms of caseload, but improving in its rate of daily deaths, when you look at the numbers per population, we fare a bit better in caseload compared to other states and worse in deaths, at least based on these CDC numbers. So this is our standard daily caseload map using a 7-day moving or rolling average. You can see that we might be starting to level off a bit. And Dr. Caldoun, Chief Medical Officer for MDHHS, implied yesterday in the governor's press conference that she's hopeful that it is leveling off. There is some indication it could be. And of course, it's always good that our overall number of daily deaths does continue to decline. And those numbers are looking really good comparatively. So this is the MySafe Start map as of 7/28, and it has changed from last week. You'll note that there are no longer the red high risk areas on the map over Lansing and Grand Rapids. And Grand Rapids has been showing some decline in cases overall. However, in the other areas of medium high risk, which is most of the state except for Traverse City area, there does continue to be increases in both numbers and rate of positive tests. So I have to look closely at that as we move forward. During the governor's press conference yesterday, Dr. Caldoun was asked why Grand Rapids remained at high risk for so long when Detroit had a similar amount of cases per million population and a positive testing rate as well. But apparently the determinations, according to Dr. Caldoun, are based on many epidemic factors and not just those few numbers that are listed on the dashboard. So they put a lot more consideration and thinking into the entire situation, not just a few numbers. But so in some parts of the state, we do seem to be improving a bit, and that's good. This week, CMS listed some outcome data for Medicare beneficiaries in COVID. Black beneficiaries continue to be hospitalized at higher rates than other ethnic groups. The only group with higher hospitalization rates included persons with kidney disease. Persons who are dual eligible also have very high rates, and CMS reported that they have so far laid out $2.8 billion for hospitalizations related to COVID to date. Before we move on to resources and new guidance, we want to spend a few moments looking at our data from our polling last week for state lab turnaround times. You can see that most members reported an average of 2 to 4 days, which of course is improved from before, but we know that labs with the increased testing, labs excuse me, also have increased backlogs. This was just for state testing, this slide. The next slide is about community lab testing, and most members reported, again, a turnaround time of 2 to 4 days, although a large number reported 1 to 2 days, and many reported more than 6 days. So there's a lot more variation in use of community labs in terms of reporting. So when we combine the data here, we still see that the most frequent response was 2 to 4 days, but the goal is for 1 to 2 days. So we're still not making that, and there's still a lot of backlog, and there's still a large number who wait for reports more than 6 days, and that's not good. When we looked at staffing in nursing homes, most reported over 3.5 hours per resident day for direct care staff. It's hard to compare this to previous numbers for several reasons, but it does seem that it has gone down a bit, at least intuitively, from before the pandemic, at least in this group of respondents. Only one nursing facility reported that they could not staff a dedicated unit. For AFCs and HFAs, the reporting was a bit different. Only 26.1% stated that they could maintain their previous level of staff, and 61% did not have enough staff for a dedicated unit. That's significant. Our last question is about caseload, and you'll notice that this table's a bit sparse. Over half of the SNFs had not yet had a case so far. That's good. But other residential settings have had proportionally larger numbers in terms of previous cases and some current cases. But it's important to note that for this element, we didn't have a lot of participants answer this question, and so our numbers are rather small, and I'm not sure how meaningful at this point. We did look at the respondent, the type of facility that was responding per se for each of these questions, but still we don't have enough information there about caseload. So our key messages from this exercise include that most facilities get testing results in 2 to 4 days, but of course we want to keep measuring that because almost a quarter do not receive tests by the 6th day. And this is the information that we want to inform our policymakers with, and also the task force. Most SNFs have fairly good staffing numbers yet, but 61% of non-nursing home settings cannot staff a dedicated unit if they needed to have a dedicated unit. We're not even sure that most of these, facilities would need one. And at this point, 57% of facilities reporting had at least one positive case at one time, and hopefully that number will not increase much. So with that, let's pause a minute and see if there are any questions before we move on to resources and guidance.
All right, thank you, Deanna. Again, Leading Age Michigan would just like to remind you guys to take a look at the logos up on the screen. These are some of the great organizations that help our association and your organization as well. So if you do have a chance where you do need to consider making any type of purchase of any type of goods and services, please remember these logos on the screen and try to purchase something from one of these fine organizations. Right now, I just have one question. In your conversations with state officials, has there been any indication that they will publicly report cases in IL, AL, HFA, AFCs? What is the rationale for reporting cases if the data is not being disclosed?
The answer is no. In fact, part of, I think, the difficulty is that there's a different group working on testing and reporting for non-nursing home settings than nursing home settings. So the nursing home setting group has been quite communicative over time, has taken our input over time to a large degree, obviously not always, but we've worked very closely with them. But the other group is extremely exclusive, and we get almost no communications with them, even though we have worked at it considerably. We can keep trying to do that. I'm hoping that even though the task force that's been put together is specific to nursing homes technically, there was a lot of discussion about thinking about long-term care issues overall, and there is a data collection work group that is at this point still in the one of the committees. So we're hoping that that issue will come up there. But we haven't seen the final committee roster and the final set of committees as of this point. But we will continue to work on it, and we consider it a problem that we don't have full transparency about what's going on.
All right, thank you for that, Deanna. Right now, I believe that is the only question that we have, so we can go ahead and move forward.
Okay, so for resources and guidance, in a preprint article that was issued this last week, researchers identified that in order to justify discontinuing social distancing behaviors, we would have to have a vaccine given to 75% of the population, and the vaccine must be 80% effective. If you know anything about vaccines, such as flu vaccines, you know that they are not 100% effective all of the time. So there needs to be an efficacy test for each of these. So those are rather high numbers. If the vaccine were given to 100% of the population, in other words, everybody, it would only have to be 60% effective to really decrease the spread of really eliminate the spread of any virus. So it's these effectiveness rates, meaning how many persons would effectively be immune from getting the disease, that the researchers are beginning to look at right now. The CDC has issued its severity of illness categories, and they made them in alignment with the definitions from the National Institute of Health. They have identified 4 general categories. Mild illness is the category for persons who are devoid of actual breathing difficulty and any abnormal imaging, but the person would test positive and have some mild other symptoms. The moderate category has some signs of lower respiratory disease, but can still maintain their oxygen levels on room air. Severe cases have acute breathing difficulties, and critical patients will have moved to actual respiratory failure, septic shock, or multiple organ dysfunction. So when they talk about severe illness in terms of test-based versus symptom-based strategies, they're talking about the severe and critical categories. The CDC has also identified a set of descriptions for persons who are immunocompromised. And this is important because, again, this is the only category left, along with persons with severe critical illness, that needs to use a test-based strategy to discontinue precautions. While most persons in this category are likely to be receiving chemotherapy or have untreated HIV, or maybe even getting treatment with large amounts of steroids over time, it still needs to be judged by the clinician on a case-by-case basis. Generally, although age and diabetes and even kidney disease can provoke some immunosuppression, these are generally not enough to affect decisions about when to discontinue precautions. But then again, it still needs to be looked at by the clinician on a case-by-case basis. This week, the OIG updated its work plan, and there are 2 areas related to COVID in nursing homes that they're going to be looking at. First, they're going to be doing a report on the characteristics of facilities who had the highest number of COVID residents who died along with some strategies taken to respond and decrease the impact of that. And they're also going to be auditing for accuracy and completeness of nursing home COVID reporting. But both those reports will probably not be available until next year, but they're looking at these things now. Over the past week or so, we've gotten a lot of guidance from the Bureau of Professional Licensing. And these are the people who oversee all of the licensing and certification provisions in the executive orders and, of course, in general. They have addressed a lot of the key issues that impact our members related to the governor's rescission of those licensing flexibilities through 2021-50. That's where she rescinded a lot of the old executive orders, and also the rescission of 2020-82. The Bureau has determined that for those provisions that allowed expansion of scope of practice and supervision, in other words, allowed some professionals at a certain level of licensure to do a little bit more than normal, those providers will have until August 31st to go back to normal. The ability to use professionals licensed and in good standing in other states was rescinded as well, but it is also covered during pandemics through a law that is separate in the Public Health Code, and that but the actual law number is listed there on the slide. Since pretty much all licensure exams are now available, the Bureau is going to require that any application for exams after July 2nd will have to be completed before the person can act under their license. So if applications for exams occurred before July 2nd and during the pandemic, that exam has been waived and will be continue to be waived until 6 months after the emergency expires. However, they do encourage everyone to get their license as soon as possible. And the link for this guidance in general is noted on the slide. In addition to that, the Bureau will continue to waive CEUs as part of the renewal process. That has not been rescinded, but they can only do this during the emergency, and that emergency is now scheduled to end on August 11th, but will likely be extended further. Executive Order 2020-82 included the use of pandemic work hours as CEU hours, but that part has been rescinded, so that the Bureau is going to recognize any work hours spent in response to the pandemic between March 17th and June 9th, and those could be considered CEU hours. Those hours have to be accumulated during the current licensing renewal cycle. In other words, you can't save them up or anything. People must still renew their license by the expiration date as usual. There's been no waiver of that. And the provision to allow use of persons licensed in good standing in other countries will be in effect through the state of emergency. So that piece has not been rescinded. Remembering again that the state of emergency currently is in effect till 8/11, but we expect an extension beyond that. Leading Age has informed us, and I believe Dalton sent out a note to AL providers last week, that Congress, HHS and Congress is looking at providing some monetary relief for assisted living providers, but they're still very early in a researching stage, more or less. So HHS is looking at private pay providers, and they want to gather information about senior living, assisted living, memory care, and life plan communities. Oddly, I think we got this just a few days ago. The deadline for information gathering is July 31st, and Leading Age is working with other entities to put a portal together for that data collection. We have yet to see that portal as of this morning, and so Dalton is trying to communicate with Leading Age to see where it is, because we think this would be an important piece if it would foster member ability to get some provider relief in assisted living. Members can contact Dalton here in Michigan or Nicole Fallon at Leading Age, and hopefully we will have a response to from Leading Age this morning, and we can send it out on the listserv. Leading Age has also put out a lot of guidance about the HUD Supplemental Payment Notice H20-08. This will cover Section 8, Section 202, and 811 housing. Any of those can qualify. There is an application process and form. The links are there. Apparently, they are going to be issuing two types of payments: a standard payment per property, and then some providers may qualify for an additional payment if they have experienced exceptional COVID costs. The links for this guidance is here, and Leading Age has put together an amazing set of resources for review. And of course, we will send the link as part of the QA later. We also want to remind everyone of several trainings that are being presented by the feds. The first is a CMS nursing home call, which is scheduled for August 12th. You can simply dial in for that. Then there is a CMS training on COVID-19 knowledge for frontline staff. That is for tomorrow. A registration and information link are also included there. And last, there is a HUD/HHS training on telehealth this afternoon from 2 to 3. And the link for registration there is at the bottom. So now we're going to go to perhaps the biggest subject of the day, and that's about testing again and test-based strategies, since new guidance has come out this week from MDHHS. So in review, because that guidance is in alignment with the CDC, we're going to start with that. And basically, they have found that concentrations of the virus diminish rapidly after onset of symptoms. So that's really a good thing. And it's generally gone for most persons after 10 days. It could extend to 20 days for those who are immunocompromised and have a decreased ability to fight the virus. And they've identified also that if exposure occurs 6 days or more after onset of the illness, others generally do not become infected. They could, but they don't. So usually there's only a 6-day window of infectiousness when someone, after someone develops symptoms. Although some recovered persons could still test positive for up to 12 weeks. The CDC also considers the time frame for protection from reinfection to be probably at least 3 months, but they're not sure yet. And there are not even any clear cases of reinfection to date. So with that, the department, MDHHS, updated their testing guidance this week. This testing guidance is really in the form of a FAQ that was originally issued on June 15th. So we're going to go over some of the more important parts, since that guidance is rather long, because we still get some questions about a lot of this guidance. The first thing to remember that who has to be tested by nursing homes. Following initial or baseline testing, nursing homes must test all new or returning residents on admission unless they have been tested in the last 72 hours. Weekly testing for all residents and staff if there are facility-acquired cases currently, and weekly testing for all staff in regions of medium or high risk, and that means all of Michigan right now. The department did approve the use of antigen testing. There was some question about that in several media stories, and that was included in the guidance. So the antigen testing, that is the type of testing in the point of care tests that are coming from HHS is covered as part of weekly testing. And the table here identifies the responsible party for each of the categories for testing. The department put a lot of energy into identifying options for persons who refuse testing. This has not really changed. We are still a bit bewildered about the fact that facilities have options based on their own policies and their own contracts where they can potentially dismiss someone who, staff members who refuse testing. But they also could have a policy to consider offering other work assignments or so that there's no contact with any nursing home residents if a staff person refuses. So you could move them to some other area, but all other staff who are in the nursing facility itself or on that nursing facility campus has to be tested as well. So in essence, you'd be putting them with other people who do have to be tested. So we've still not gotten a good answer to that question, but that continues to be in the guidance. And of course, even though a guardian or durable power of attorney has control of decision making, you cannot restrain someone and force them to be tested in any case. So, and you'd have to look at all of that on a case-by-case basis. They do hope that you work to educate the resident as best you can as to the importance of testing, but they still have the right to refuse. One thing that we found is that we get a lot of questions about the scheduling and timing of training. So persons on vacation or other leave can be excused from weekly testing, but they should be screened and tested on returning. They can work while waiting test reports as long as there's no concerns through their screening about possible exposure or any symptoms, of course. Newly hired staff, though, have to have a negative test in hand, no more than 1 week prior to direct resident contact. And staff who work in several facilities only have to have 1 test per week, but they need to make sure that all the providers or facilities they work at have the documentation that they have been tested. So this is the part of the guidance that has changed, and the changes are really all based on the CDC updates that we have discussed earlier. If doing weekly testing in residents and staff, you must continue testing until there are no new positives for 14 days. That part is not new. But persons who test positive do not have to be retested for 3 months as long as they remain asymptomatic. And that's because the data review makes it look as if they will continue to test positive for a long time, and persons who are asymptomatic generally have not been reinfected. In fact, they don't have any data about persons being reinfected. So they believe that continued positive tests really are about the initial course of illness. So it makes no sense to try and test those persons. If they do become symptomatic, though, in that 3-month period, you must retest and evaluate them on a case-by-case basis. After 3 months, if a former positive person becomes again becomes again symptomatic, you do have to retest and consider whether or not they have other respiratory conditions as well. Again, test-based strategies are now recommended only for persons with severe COVID illness or who is immunosuppressed. And so you should be applying the updated symptom-based strategy for return to work or discontinuing transmission precautions for everyone else other than those immunosuppressed or persons with severe illness. There's some additional points from the MDHHS guidance. Remember, you should keep your testing plan up to date. You are required to use their template. And in the last few weeks, they have included new fields in that template to enter information if a facility cannot complete testing. And there's a place to identify what the barriers, what the reasons are for your inability to complete the testing. Remember that false positives are very unlikely. It's much more probable to have a false negative. And facilities should be careful because even with negative tests, it's possible to have a positive person, staff, or resident on campus. So this will even be a greater risk when the point of care antigen tests are used. I think they have something like a 25% false negative rate. Remember that when you have to do weekly testing, if you have a case on campus, you only have to do that testing if the case was acquired on your campus. If you admit someone COVID positive, you do not have to do that weekly testing. We've had some questions about this part of the guidance because in the guidance, they, out of the clear blue, define what resident contact means. And some providers who've talked with us have thought that that meant they only need to test persons who have resident contact. If you have to do weekly staff testing, you have to test everyone. This definition is really only here to identify where a staff member can and cannot work if they refuse to be tested. It's not about who you test. You must test all employees on your campus in a nursing home portion. Some other reminders about the guidance. Antibody testing has no bearing on the testing requirement. They still need to be tested weekly with everyone else, whether they've been positive or negative. Providers must continue testing even if the results are not back on time. And a new provision here is about if there's a suspected exposure. If your staff or your residents have a suspected exposure, in other words, someone was in the building who had contact with someone who was exposed, you must test all residents and staff as soon as possible. But if you're already doing weekly testing, you should consider the timing of the next routine testing, and using that date might be the most practical. Depending on your own policies, asymptomatic staff may continue working. And this provision seemed a little vague to me. It says, depending on your own policies, asymptomatic staff can work, but you need to look at them on a case-by-case basis and perhaps how close the contact was. So there's a lot of independent judgment about that piece. Testing reimbursement. These portions are new in the last 2 days. So there are new portions of this in both the guidance and the testing reimbursement form. We have gotten confirmation that Medicare Advantage plans, Medicare B billing for long-term care patients, or Medicaid billing for any resident or staff, that billing should be done by the lab directly. However, Medicare A, fee-for-service testing for short-term stays, has to be covered under consolidated billing and should be included on the UB. The department will reimburse for any testing that is not paid for by insurance, and they will cover the costs for Medicare A fee-for-service billing, and the testing reimbursement form has been updated to include that. The testing reimbursement process is listed here. Remember to use the most updated testing form, which is on the website and was updated on Monday. I think that we also provided a link to it in our update on Monday afternoon. The department suggests nursing homes submit reimbursement forms at least monthly or bi-weekly. The Bureau of Community and Health Systems also put out updated guidance yesterday regarding nurse aid testing for certification. Under both federal rules and the federal waiver, nurse aides whose testing was waived can continue to work as a nurse aide until November 1st. To continue working past that date, they must pass the exam and become certified. The federal rules that allow a facility to employ an individual as a nurse aide is still in place with the qualification that they can work for up to 4 months. So that rule has not changed. And there is the link to questions about this at the bottom of the slide. So a few other final updates. As we discussed earlier, Michigan will approve the point-of-care antigen tests for use as weekly or any other testing. But Michigan currently has no providers who are on the priority list at this point. So tests are not coming to Michigan in the near future. The waiver for submitting information for the SNF QRP is lapsed. Starting July 1st, SNFs are expected to resume timely data collection since it was the timely data collection was waived during the pandemic, at least the first month of it. This is all MDS submission based, so if you're keeping to your regular submission guidelines, you should be good. Okay, we didn't have a lot of new pieces, but we had a lot of details, so we can take questions about any of these guidances now.
All right, thank you, Deanna. Before I get to the questions, I did just want to mention I had some people saying that they weren't able to get the handouts or they weren't working. So when we send the Q&A document, we also will be sending a recording of this entire webinar, and then we will also send the PowerPoint along as well. So you should have that within the next day or two. All right, now I will just get right into questions. When was antigen testing approved, and can you send a reference?
It is in the guidance that we were just going through, the FAQs for testing. I actually did not notice it before. I do not think it's new. I had thought in reading some reports when the point of care test came out that Michigan was cited as a state that did not approve antigen testing, but apparently they have. It is in the links to the guidance, the FAQs, testing FAQs now. So I'm not sure when they actually approved it, but apparently they will take those, they will allow people to use those tests.
She also just asked FA guidance from who? Or FAQ guidance from who?
From the Department of Health and Human Services, the testing FAQs that we just went over in detail. The link is there, and when I get this question, I will send it to this person specifically.
All right, sounds good. Since the national and state expiration date for the state of emergency is so important, do you think the governor will ultimately align those expiration dates with the national date?
Just off the top of my head, my personal opinion is no, because what's going on in Michigan and what could be going on in other areas is different. I think the governor prides herself on looking closely at what's going on in Michigan and tuning into that. I can't imagine, there's so much dependent on whether or not a state of emergency exists in terms of funding and resources, that I still can't imagine that as of 8/11, that's going to go away.
Okay. Please clarify, if an employee has been exposed to a person, not a resident or coworker, who has tested positive, are they allowed to continue working if they are asymptomatic?
Well, that's the part that is really vague. The guidance that came out of the department, which we just went through, and you'll have links to if you don't already, says that they can continue to work based on your policies. However, in other portions, there's the idea that if someone has been seriously exposed, they should be treated as if they're positive too. So I think there is no clear answer to that. I think it's one of those gray areas that unfortunately exist. And if I were a facility, I would look at every case differently. Or if you choose not to have those persons in your facility working, you certainly can do that. You should just have a policy to make sure that that's something that you do on a consistent and routine basis. So it's vague. I don't have a better answer than that. And facilities can use their clinicians and medical director to help determine what their policy should be.
All right. What is your interpretation of the CDC guidance on face shields? Do we need to wear them in AL and sniff?
I would say that's a hard question. The CDC recommends use of face shields in all these congregate residential healthcare settings at this point because of the high rates of transmission. I do know that that's a recommendation that I have not seen made mandatory by either CMS or the state. Again, there is a lot of guidance that implies that CMS requires these things that the CDC recommends, but sometimes they specify those and other times they say review those recommendations. So unfortunately, this is another area where it isn't clear. I would look at your local transmission, because part of the problem with Michigan is that we have such huge regions of transmission. So right now, if you're in the upper part of the lower, where transmission is a little bit less, you could be in a county that has very low transmission rates and consider whether or not you think that you need to have face shields for direct caregivers. There is always some risk of infectiousness, especially during procedures, and you might consider that if you have any aerosol producing procedures, you should definitely have a face shield on. But I think that considering the fact that the CDC guidance specifically says in areas of medium or higher transmission, I would look at my community and make a decision based on that.
All right. Will the state reimburse a facility for performing the tests if the facility buys the equipment to conduct the test?
Yes, they will pay for collection, just as if they would if they were providing the equipment for the test. And that is in the Q&A. I just didn't highlight it today.
All right. And then I just noticed I did get a couple comments regarding the previous question. One person said our survey manager in Northern Michigan stated they would cite for not wearing eye protection, and then another person said even in this upper lower risk area, our survey manager did state that the eye protection would be expected and enforced. Just
okay. So that's good to know. It's good to know how the state is reacting to that.
all right. 1 second. With PPE shortages, is it acceptable for trained staff to train those who have not completed PPE competency at the time that transmission-based precautions are required?
Can you repeat that, please, Blake?
Yeah, that's fine. With PPE shortages, is it acceptable for trained staff to train those who have not completed PPE competency at the time that transmission-based precautions are required?
So you're talking about just-in-time training. is my interpretation of that. And I would think that that would be okay. I think that if you're a nursing home, the surveyor is going to expect that that everyone be trained overall in infection control and transmission-based precautions. So if you're thinking that that would alleviate all of that other training, I don't think so. However, I'm not an expert on survey, and we will take that question to Laura Funch, and we will discuss it and send out a more refined answer in our Q&A.
All right. Who is considered an infection control consultant for purposes of a LTC directed plan of care?
I believe that Laura Funch has put out a list or has provided some guidance to that. I don't know the specific qualifications myself, or even if they are identified in detail anywhere. But again, we will send out those resources to this person when we get the Q&A.
All right. Can a trained observer complete observations for the infection preventionist to monitor compliance with PPE and hand hygiene?
Again, I cannot speak to, I believe that's under the directed plan of correction criteria. I can't speak to that. I will have to defer to Laura, and we will include that in our Q&A.
Okay. Are hairstylists allowed in assisted livings and independent livings? We're aware that some facilities are allowing this, although the executive order technically does not allow visitors, which would include hairstylists and cosmetology. We heard that one facility was calling these services essential in order to be able to provide them to residents in AL and IL.
We are aware that some facilities are doing that, and we understand the reason for that. Although the visitation guidance does not list hairstylists as someone with an exception, technically you could consider that hairstylists aren't visitors either. So this has always been a gray area. The only reason why we have not promoted the idea that it's okay is because we did know that Laura looked at this very closely a couple of months ago when they were updating their FAQs for assisted living level providers, and refused to include in that FAQ the hairstylists were okay to use. So because of that, we believe that they consider them outside of the essential worker / visitation guidance. But we do know that it's been a challenge for a lot of members, and some members we have heard have been doing it. Again, not a great answer. Unfortunately, I don't have a lot of good answers here. But we do know that Laura considers that not appropriate.
All right. Do residents have to be quarantined for 14 days regardless of known COVID status? I'm assuming maybe new residents? Yes. Okay.
Yes. Let's be very clear about that. And it is in MDHHS guidance. It is recommended by the CDC, but it is in MDHH guidance. You must, even if you test and even if you have 2 negative tests, you must isolate new admissions for 14 days after they come to your facility.
All right. So when looking at the eye protection mandation, it has to be worn at all times, only in rooms of new admissions, or during all resident contact?
I'm sorry, Blake, I didn't get the first part of that. Can you please repeat it?
So when looking at the eye protection, it has to be worn at all times, only in rooms of new admissions, or during all resident contact?
The CDC recommendation is that you must wear, or you should, because it's a recommendation. Staff in direct resident care in any part of a nursing home or other facility should wear eye shields if they are in an area of medium or high transmission. In other words, if they're in a county or a local area where there's medium or high transmission, they should be using face shields for all resident care. Now, Michigan technically has a medium level at minimum across the entire state. So if you wanted to use those regions as that guidance, then technically all facilities should be using face shields for resident care. And apparently, surveyors and managers are citing for that, according to one of the callers.
All right. Now, if anybody does have any further questions, something they think of after this concludes, you can feel free to shoot those questions to the emails there at the bottom left of your screen. We have the Safe and Calm. You can reach out to Deanna directly, Dalton directly, or Laura Funch. That does look like that was our last question. So we would like to say thank you to both Dalton and Deanna, and we would also like to thank our members and participants. I believe that we got up to almost 95 people on today's webinar. I think that might be a new high. We were really close to the 100. So thank you to everyone that took the time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, we will be sending out the PowerPoint along with the recording and a Q&A, probably either today or tomorrow would be my assumption. And then another reminder that we do have another Safe and Calm webinar this Friday at 11 a.m. Eastern Standard Time. Thank you everybody for joining, and I hope everyone has a great day. Deanna or Dalton, do you have anything else you'd like to say?
This is Deanna. I would very much like to thank everyone for their patience and tolerance and their hard work as we move forward, because it doesn't look like this is going to end anytime soon. And we will continue to try and assist you in any way that we can. Please remember to shoot us an email at either one of us or at Safe and Calm, and we will try to respond as quickly as we can. So thank you.
Oddly enough, I just got the email back about the assisted living survey portal. They say they are working on testing that portal out right now, and they're planning to distribute that this afternoon. So pay attention to the listserv, and I'll be sending it out there.
All right, thank you.
That's great. Thank you, Dalton.
All right, have a great day, everyone.
Take care.
Bye.